Check 1, 2, check. All right, good morning. I think we'll be starting. Have a seat, yes. We've got a full house. We're in tight quarters today. Well, welcome everyone, and welcome everyone on webinar. I'm delighted this morning to introduce Hilda Fernandez-Alvarez. She is a Lacanian psychoanalyst in private practice who has worked with Vancouver Coastal as a mental health clinician since 2004. She initially worked for a year with ACT Bridging, and in 2005 she moved to the position of suicide intervention counselor at SAFER. She is currently on educational leave to finish her PhD dissertation at Simon Fraser University, and I think she might be telling us a bit more about that. She's an experienced clinician in the mental health field within hospital and community settings, and Hilda has a solid theoretical background of Lacanian psychoanalyst and social theories, and is trained in diverse modalities of psychotherapies. She earned a BA and MA in clinical psychology in Mexico, and an MA in Spanish literature from the University of British Columbia here. She has published a number of peer-reviewed articles and book chapters related to psychoanalysis and psychotherapy, as well as socio-political themes of contemporary relevance. Thank you for joining us today.
Thank you. I'm very happy to be here, to see so many familiar faces. I feel at home. Well, I'm going to be talking about my research. Yeah, that thing. Yeah. There you go. So the title of my research is called Understanding Trauma and Recovery Practices Among Users and Providers of Trauma-Specific Services within Mental Health and Substance Use Sites at Vancouver Coastal Health. I'm going to be talking about these in the next 45 minutes. There are two different titles for this research. The one is for the SFU dissertation is called Mapping the Discursive Spaces of Trauma and Healing, the Institutional Unconscious, and the team grant title, we already said it. And I want to make some acknowledgements. First of all, we are on the unceded territories of the Squamish, Tsleil-Waututh, and Coast Salish peoples, and also to express my solidarity with the Wet'suwet'en Nation. I also want to acknowledge the BCHR Research Institute team grant, because they funded, and it was very helpful. The research team, which is constituted by me as a principal investigator, Dr. Marina Moro, who is a co-principal investigator. She's the professor and chair of the School of Health Policy and Management at York University, and she's also part of my PhD committee member. Dr. Paul Kingsbury, who is here, professor in the Department of Geography at Simon Fraser University. He is my supervisor, mainly. This research had a number of advisors: Dr. Larry Ong, who is a clinical psychiatrist and instructor at BCH and Raven Song; Dr. Margaret Drulo, who is a psychologist at Outpatient Services; Jerry Ostrochanski, my very good friend, SAFER counselor at Outpatient Services; Gary Allward, a colleague at Outpatient Services, all of them highly esteemed. And Kelly Elliott is a very special person who was my advisor as part of the engagement network. She's a client in the system, and she has been in different kind of projects. She's from the Same Nation. I'm not saying it properly. Well, sorry about that. But she has been super helpful. I'll talk about that. Also, the research assistants, I don't know what I could do without Andrew Regis. He has been like so key to help me managing all the staff. And my beautiful friends, Ashley Hicking and Rachel Unipan, who are also research assistants. Finally, I want to thank other people such as Christina Vasarhelyi from the Research Institute. She has been a great support. Savi Osla my manager from the outpatient services. She has been all the way supporting this research. Professor Samir Gandeshan from the SFU Institute for the Humanities, my SAFER colleagues all over the many years that we have shared together, and the Lacan Salon colleagues who are kind of my intellectual buddies. So let's talk a little bit about the research design. So the antecedents of this research relate to the trauma-informed practices, which is a guideline that was implemented in 2013 in all the coastal region. This research tells us that 76% of Canadian adults have trauma exposure, and 90% of women with mental health and substance use concerns have trauma history. So that makes our services, whether or not we are doing it, our services should be trauma-specific services as core services because of the high prevalence of trauma in the population we serve, and we all know that. The research questions of my project is trying to understand how clients see trauma and experience recovery, and how practitioners conceptualize trauma and facilitate recovery practices, with the objective of providing an in-depth understanding of the interpretative frames that shape the way clients experience the trauma services and how practitioners actually provide trauma recovery. The secondary objective is to enhance and complement the services with the hope that we can inform policy. This is the participants that we had. In total were 25, 7 patients from all these different 4 sites. The sites that participated were outpatient services, mental health substance use, in Seagull building, mental health team. We had 2 mental health teams, Kitsilano and South. We have Aboriginal wellness and substance use services at 3 Bridges. And you can see different kind of numbers there. We had also a focus group that was constituted by clinicians from the different services, as well as managers. So 25 interviews in total. How was the recruitment? The inclusion criteria was that for clients, they had to be at least 3 months in our services. They were between 19 and 90 years of age, and they mainly have to be willing to participate. In terms of the clinicians, it was Sarvi, my manager, helped me to send around all the different teams kind of blurb inviting people to participate in this research, and the teams that responded were the ones that were included. The exclusion was with regards to clients, those that were my patients. I couldn't include them in the research. And we will talk a little bit about attrition later with regards particular to the Aboriginal wellness team, but also in terms of clinicians, we didn't get any representative from the docs. Like we didn't get any psychiatrists on board for this research. I sent it around. Also, yeah, the attrition with regards to clients, I think that was affected because I will talk about that in terms of the how do you engage people for participating in these kinds of research if you don't have a relation. So we will talk a little bit about that. So the methodology for this research constitutes of 3 different methodologies that come from the psychoanalytic geographies and also from the social sciences at large. It's participant observation, ethnography, and Lacanian discourse analysis. So first a little bit about the discipline so we can contextualize where I am coming from. Human geography is social sciences that is particularly concerned with studying the human experience in the different dimensions of the social, the economical, the political, the historical, but also the psychological. It works mainly with the scale, so it can study the globe, it can study the city, it can study an institution or an individual or the body. So it has a lot of different scales, and also bases its analysis on space, on the concept of space. Space, we know that there's geographical space, but also there are other forms of the spaces that are created emotionally, psychologically. In my research, mainly we are talking about socio-spatial discourse. And what do I mean by that is precisely the exchanges that we establish with people in the day-to-day practice that we have. Psychoanalytic geography talks about trauma and healing are not in the person's head. It's not an individual problem, but it's more in the socio-spatial relations that are embodied, and that by that means we put the body in these exchanges, and it's dialectic. It's dialectical. It's always in relationship to others, and also the trauma exceeds the ability of the person, the symbolic ability to articulate what is that about. So those are kind of the main tenets of psychoanalytic approach for trauma here. I know that the unconscious has been out of circulation for a long time in these spaces. However, in the social sciences, it's a very vital way of critiquing the way we experience life, but also clinically there are a lot of people using psychoanalysis in many other parts of the world, including Vancouver. So Lacan, it's a psychiatrist from France that he takes the kind of the basic tenets of psychoanalysis from Freud, and also he mixed his theory with the rigor of linguistics, which is mainly all the social sciences are concerned with language. So he takes the linguistic theories, and also he bases a lot of his kind of work, which has been for 50 years. He worked in France, and he has been very influential. He also works with philosophy and mathematics to create some topological models. So instead the unconscious being something that is hidden and that we have to go into the depths of what that means, for Lacan, the unconscious is present in our language all the time. So there are some mechanisms that kind of hide a little bit the unconscious while we are speaking, but the unconscious is already there. And something very important that this slide is important because this contextualizes the results that I'm going to be presenting. We are not talking about persons necessarily, but we are talking about discourse, how the language is layered and have effects and results in the way we practice. We are not trying to get against anyone or any person. It's more like what is the discourse that seems to be circulating in our institution. Briefly, the institutional context, we know that the Canadian mental health system is working with collaboration, innovation, and accountability, and have many kind of objectives. Some of them is kind of having more community-based mental health substance use for children from 10 to 25. They are trying to do early interventions as possible, working with evidence-based models of community mental health care and culturally appropriate interventions that are integrated with primary health services. These are important words because those are things that are very alive, but are we materializing those things? Are we materializing the culturally appropriate, the community-based, or not? And then also they are trying to integrate community-based services for people with complex health needs. The financial forecast is $5 billion over 10 years from 2017 to 2019. It was $100 million, so how are we going to spend the rest? I think we should have a saying there. The provincial, it's another kind of scale. BC, as we know, has the country's highest rate of hospitalization due to mental health and substance use. As we know, the horrible tragedy of the overdose crisis has, up to 2018, has caused 10 deaths. Indigenous peoples experience the greatest barriers to health care, and they say we need equitable access to culturally safe and effective care. People need safety to heal. According to my copy eye, she says that BC, in terms of policy, is one of the leading provinces in Canada in mental health care reform. Finally, we are very familiar with what are our mandates. We serve outpatient, inpatient, and in-home settings, people with psychotic disorders, mood disorders, concurring disorders, and substance use of different types. So that's the context of the institution. And let's go to results analysis. Before we go to results analysis, I'm going to spend the most time that I have left in talking about the results rather than talking about all the scholarly work. This is becoming a manuscript that I'm sending to peer-reviewed journals, and I would be more than happy to send around. But precisely for the sake of hearing the discourse of our institution, I'm going to put more emphasis in the results rather than the discussion kind of with other voices that are from the scholars, if you know what I mean. So the first level of analysis is ethnography and participant observation. This talks about transformation. The first thing that I ethnographically encounter is the transformation. I have been here for 14 years, the transformation of services over time. And there are two kind of quotations, one from leadership that says, these days managers have multiple sites, and I do not have the relationship with my frontline staff that I would like to have, or that I had with my manager reversing back 8 years ago when the managers weren't spread so thin. And then we have a clinician that says, the individual therapy got slowly, lost staff, and then they wanted me to just mostly do DBT at that point. So then there was nobody to do that and came up with a new protocol, which is the one they have now. So it has been cutting the ability to provide services that we used to provide not too long ago. And I put the potluck because I think that affects the morale. Like if you want some meter from my research, let's talk about the potluck meter, right? Like when we invest voluntarily our energy to bring something to share with our colleagues, we're talking about a very high morale. Not that we don't have that initiative right now, but I don't see the same potlucks anymore. We used to be in homey kind of environments, offices that now are more like kind of aseptic, impersonal. Those things affect the way we feel in our workplace. Another part of my ethnography and participant observation refers to the ethics review. I found the process quite torturesome, as possibly many of you have experienced, and mainly because I didn't find a collaborative kind of dialogue. It was more like authoritative. And there was according to Nancy Cass and her team from the Johns Hopkins Hospital, she talks about the ethics for a learning healthcare system that she calls common purpose, right? That has to do with bringing collaborations, with trusting the clinical judgment of the clinician instead of the distinction paradigm. Because also there's a tendency to overprotect the clients. For example, under the deficit assumption that, according to the GLOMA, that the patients particularly are not going to be able to tolerate some kind of the research questions and whatnot, and that prevents us from getting to the important questions to ask them because they are very protected. This is an important example of my ethnographic experience with the Aboriginal Wellness Team. I'm so grateful for the experience. I learned a great deal. Probably this is the most significant learning that I had in this process. And I'm not going to have time to talk about all the 4 things. Mainly the relational aspect was very important. And by that I mean is that the relation is embodied and present. If there's conflict, it's frontal. And then obviously, as any human relationship, you can be a little bit upset or annoyed. But that allows for getting a different way of result and a different way of relationship. With my research advisor, I got a great deal of understanding about what is the difference between the social historical trauma and the developmental trauma. We were meeting every month over sushi, and I really understood there that difference that has to do with when the state sanction abuse, there's no law, and that right there I understood. I'm going to talk about that in the manuscript. But I want to, and then the Council of Elders, that was a very intense experience. I arrived with them, very graciously offer my tobacco as the protocol. Then I jump the protocol and burst into tears for 3 minutes, sobbing. So that speaks about the aspect of shame that I would also would like to discuss in the paper, because there's a lot of other things. But attrition with regards to the patients. The ethics review has passed. The community engagement with the population of Aboriginal Wellness Team had been ample, kind of extensively consulted. I got the blessing from the elders, but at the end the team decided not to let the patients participate, and I thought that it was a brilliant thing. And I'm bringing this picture that is Erase Lynchings by Ken Gonzalez-Day, who is an artist in LA, that I encountered in Tuck and Yang, some post-colonial theories in different areas of social sciences. And they talk about this image. The artist presented the lynching without the body, without the corpse hanging. So then your gaze turns around who is participating of observing that lynching, right? So it takes away that kind of content of humiliation and pain that Tuck and Yang are talking about. It's something that you put out there for commodification of pain and suffering, and for victimization of the kind of disenfranchised communities. So I thought that it was a brilliant thing that they decided not to participate. So the second level of analysis, I'm just going to go really quickly here. It's 6 units of analysis that consist in core signification of trauma. What is the place of knowledge? What is the place of otherness? What I am assuming the other is. What is the place of agency? Where is the articulated truth? And what is the expected outcome? So I apply this to the interviews and more than 50 scholarly works of diverse evidences. So I work with Well, this is the method based on Lacan's theory of discourses that are the 4 discourses. I'm not going to go there. But this is what I mean. For each of the different research that I review, papers, I kind of establish the categories of the medical, the cognitive behavioral, the somatic sensorial, psychoanalysis or psychodynamic, expressive art, humanistics, and social justice. There's evidence for everything, right? And each one has its own kind of theoretical tenets. And then I did an analysis of that with regards to core signification and agency. And we need everything, right? We need to be healthy to feel kind of empowered in our own self. We need to be emotionally regulated and owning condition, but we need to be embodied. We need to be kind of in our bodies, but also we have an ethical responsibility, and we have some creativity that we might be having, and it would be helpful to heal, and we need history, and we need to question power. So there are a lot of perspectives to address trauma. We are only addressing the 2 first, medical and cognitive behavioral. So let's go right into the results of service users. I'm not going to be able to say everything, but for example, for the meaning of trauma for our clients is some are developmental abuse, some are regarding family death by suicide, some others are about the experience of illness, psychosis, hospitalization, homelessness, sexual abuse, developmental abuse, death, suicide, death, developmental abuse, drug use, again, the illness by itself a trauma, and the cycles of trauma repetition. Also, I'm just going to highlight what is healing for them, integration into life, accepting trauma and the effects of trauma, connecting to their truth, the sense of empowerment, the sense of social connection, to trust, to breathe again. It's a process that takes time, and it's a gift to oneself, some say. So we have here some of the complaints, right? I had one that it was what works for clients, but probably I put it later. But anyways, obviously I could join our narcissistic institution and say we are really doing great. We are doing great job in many ways. We are, but my critique is about what we are not doing good. So one client says that, one of the big complaints that I found is that clients feel that they are not being listened to, particularly in the mental health teams, even though they are happy, for example, with the case management and all kind of the other things. But they say, I don't really talk, she's talking about finding Reiki very helpful. I don't really talk about it with them. And I say, oh, why is that? I fear they won't accept it. And later she says, just I would be looked upon, down upon. Or some other people said, what I believe led to trauma, they don't agree with me. So there, this is a big one. This is like a really like a piece of, is anyone wanting to read that aloud for me? So you have a break from my accent? No? Yeah, please. Thank you, thank you.
Client 5, the entire group today spent probably a good 15 minutes bemoaning the fact that there doesn't seem to be group process or enough group process, and when the people who were around the table say, well, we'll just meet on our own, one of the gentlemen there actually said, I don't really want to do that without a facilitator. And I was like, that's fair, because we're just going to get together and have coffee and bitch about our mums. Like, that's not the same thing. But there was nothing else. The gentleman himself, he's quite a bit older, and he's said to be remembered because abuse has been around since forever. He remembered going to a group for adult children of abusers back in, I don't remember what era he said, but the group, these things go in cycles and the groups have dried up. So anything that's available right now, certainly that he didn't find that was being put on by a professional that could manage a group like that. Everything we know of is more of just kind of a coffee clatch, where we're going to talk about our traumatic experiences in a non-professional setting, maybe in a room in the library, but there's risks to that, obviously, some pretty serious risks.
Thank you.
You're
that
welcome.
Speaks by itself, right? What works well for them, this is before case management, funding, housing, psychiatric drugs, social activities, empathy, information. The client find very helpful her current case manager and psychiatrist, consistency in therapy, and trust. Now let's go to the service providers. I'm just going to talk briefly about the combined years within service of these kind of interviews. We have more than 2 centuries together, so more than 200 years of experience distributed among all the interviews. So what works well? Gardening group, an art group. There are many groups that work well. The substance use teams were very excited about the VAMP and the START programs. There's great respect for people, good relationship, advocacy, and different backgrounds and different approaches. All of these are quotations. Concerns about the diagnostic-based medical model is that we are critical and really censor everything they do, the patients, particularly in mental health, and look at it from it potentially being a pathology. Substance use is becoming more and more perceived as an extension of more medical model, concerns that a person a lot. There's a lot of our long-term workers, and the new ones need more training. And again, people can be really pathologized. The time-space needs and acute and chronic complexity. We are very familiar with these, with our caseloads that are very high. The therapy occurs in the context of relationship, and a therapeutic relationship takes time to build. There are limited number of sessions, no matter how many they actually want. We don't address the root or the cause of the addiction or the mental health distress. We give them coping skills and medication. And there's one leadership that says there's not typically a return if they have done trauma processing. I want to say that obviously my focus in this research is about trauma-specific services from the perspective of psychotherapy. So we need everything, but we have maybe to rethink a little bit the psychotherapy things. There are concerns about the high turnover with younger clinicians who need more training. The higher is based on the experience and education, but not the quality of work or the understanding of the kind of work that they do. If we are not properly trained to address trauma, we can cause harm if we don't know what we are doing. And mainly the focus on medication management. This is something that kind of was concerned in different participants. The supervision was one of the highest concerns that people had in these interviews. They require quality supervision rather than seeing us as jacks of all trade with a caseload of 70 clients. The supervisor needs to earn the respect by being in tune to the needs of the practice rather than attending administrative agendas. And it should be safe for people to make mistakes or be avoidant if they want. So in other words, there should be, as people are saying, a kind of a space for not knowing, for not being able to articulate. We are dealing with trauma. We cannot articulate the horror that we are witnessing. So that's some of the kind of things. Another one is the high complexity inherent to trauma work. It's ubiquitous. it says this person, this clinician, it is a natural part of working with people who are suffering a lot. Trauma comes up. Other modalities need to be included. One size fits all is very disempowering, and there's a strong reluctance for something that doesn't fit with CBT-oriented models. There should be cultural competency, low barriers, and specificity. Instead of one size fits all, what this particular community, for example, in the Three Bridges, they are kind of attuning to the needs of the LGBT queer community, and they are organized. They have organized for now quite a while groups that are addressing that. Also, another concern was the vicarious traumatization and the potential level of burnout with the intense and high caseloads. We know that, right? The ethical responsibility, we have inherent authority on what we do in patient kind of clinician relationship, acknowledging that and working really hard not to use that, and also give the space for the clients to take agency was one of the concerns. Okay, the third level of analysis, that's just kind of is for the larger dissertation, and it's abstracting the principles of these to understanding structures of institutions. So this is the end of results. Briefly, let's go to discussion. The dominant discord that we have here is capitalism. Maximal optic benefit at apparent minimal cost. This is the capitalist reason that has been changing for 50 years, the institutions at different levels, not only the health, but the education and also the judicial system, etc. We are kind of constantly facing acuity, chronicity, and complexity. And complicity we can be complicit to. So the complexity, I wanted to quote these two people, two clinicians. If I do this work and I know that you do not have a shelter to go to tonight and your PWD application is not done, right? What we are going to do. The therapy is limited in the sense that the problem doesn't occur particularly to the indigenous individual, but in the systems and the structures of settled society and the process of ongoing colonization. Therapy alone will not address operations. So these are the complexities we are talking about, kind of bare life and kind of larger systems. But then how do we respond to that with an all-knowing discourse? Hegemonic fetish, I call it, that we call evidence-based treatment. Now, I have to clarify, I don't have anything against evidence-based medicine because I want my Cochrane, I want my randomized clinical trials when I am getting a medication, and probably that's very important for the medical part. But it's not the same for psychotherapy kind of process. There's a large evidence of criticisms about this kind of fetishization of EBT. When I talk about fetish, what do I mean? I'm talking about the way Marx defines commodity, fetishism. It's we engage more with objects than with people. So we are more concerned about we need to apply this technique, or we need to apply this manual, rather than really engaging with the person at a kind of a more human level. Roberts and Yeager talk about, evidence-based is conscientious, explicit, and judicious use of best available scientific evidence in professional decision-making. That sounds really good. Using critical thinking. The problem with the EBT is that it becomes kind of a word that is devoid of any meaning, that is used as a shield to protect from that complexity that we are seeing. And also, it kind of makes these, using of acronyms and kind of these big words that are kind of preventing from really looking at the traumatic nature of our work. So we kind of hide in rating scale, checklists, manuals, etc., rather than really looking into that. You think that I am just inventing this? No, there are some kind of voices that said, you are teaching someone, here's the method. So the protocol is very specific and cognition-based, and so you are taking patients through a manual. Or another leadership. Alternative forms of healing would be something that would be outside of anything, that would be empirically evidence-based. I would not embed them in the healthcare system. We need much more neuroscience of the brain. I would say leave the neuroscience kind of as a good thing, but yeah, I want to know about the brain, yes, but also I want to know how I'm going to deal with this intense anxiety. We need to engage other modalities. We need to engage creativity from the expressive arts. Somatic, sensorial practices are vital, right? Like people are saying this. I'm not inventing, yeah. So there's no space in the way we are right now in this institution for epistemological uncertainty, so not knowing, and singular true specificity. We don't have a space for that. But there are many ways to counteract these with emancipatory discourses towards practice-based qualitative research, collective knowledge creation, that comes from the kind of the roots of the clients first, because they are receiving these services, and us as critical mass to design practices that are relevant to the specificity of our work. Some of examples of emancipatory discourse, culturally centered, indigenous approach, establishing enough trust and relationships. The mind is not the brain. The mind is more expansive than that. Democratizing services, again, starting from the wealth of knowledge that exists in this institution. And also, kind of, if we want to educate, which seems to be a lot of the interviews, we want to educate the client. Well, number one, we learn by producing questions. We don't learn by being fed up. And so, that's something that I want to talk. Finally, yeah, I'm just gonna talk about I think to give some space for the recommendations. Yeah, for dialogue, collective knowledge. Number one, specificity. Number two, curriculum for trauma-informed practices and trauma-specific services that include critical pedagogies. What do I mean by critical? To be able to articulate a position with respect to knowledge and lack of knowledge in dialogue with others, interested in advancing the same issues faced by the group towards a collective inquiry and potential solutions. The balance is someone that I encounter, and it says analysis, communication, open-minded, problem solving, and creativity as ways of critical thinking. Also, we need to look at the causes of the mental health and substance use issues that we see. The complexity, it has to involve all disciplines. It should be a third-level approach with cultural specificity. It should be interdisciplinary, practice-based research, and there should be indigenous-led research and initiatives where they decide their partnerships. And I want to close with this by our minister that says, and let's take action based on the best evidence, even if it means shaking up the status quo. That's all. Thank you.
All right. Any questions in the room? And again, a reminder for people asking questions to just tap lightly on the red button, ask your question, and then when you're done to just tap off, please. Any questions here or any questions to UBC? Oh, okay, Dr. Gibson.
Thank you for the talk. Can you give an example of institutional unconscious?
Yes, thank you. It's the concept of unconscious talks about those things that are right in our face, evidence-based in this case, that are not helping us to support particular ways of attending trauma-specific services, right? It's right in front of us, but it is devoid of signification. So we all say that, but we are not really looking at the effects that that particular signifier, in this case, this word, is causing effects. So that is one example of institutional unconscious. So it's something that is present, but is veiled in terms of the effects. And that structures the way we establish our practice. So in other words, there's a lot of people among the participants that have all sorts of trainings, right? Like there are people EMDR, people doing somatic, sensoriosomatic therapies, art therapy, etc. Those people are unable to use those abilities because we have this word that shapes the way we should behave. It's unconscious because we have it in front, but we don't see it. We don't see that that is a hurdle. That's what I would say about the institutional unconscious. But the idea is how mainly this dissertation is helping us to read in the social, those things, those instances of obscuring signification and kind of obscuring signification that have profound effects in practices. That's pretty much what is the whole proposal of institutional unconscious. Detra.
Good work. Just one comment I have, one thing that I didn't see in it, is the idea of therapists doing their own work. I mean, it's part of the neglect in the whole system, right, of we don't get enough supervision and training. And even if we're well trained, when you're meeting face to face with someone and you really don't want to be doing any harm, then it's really important to, have a sense of the countertransference, what belongs to the therapist, what belongs to the client, and, and the impact and the work of that, and have supervision around that for the therapist to be able to discuss complex issues. But, my understanding is that we're only going to be able to go to the depths with other people that we're able to go for ourselves. Absolutely. And the vulnerability in the unconscious is to project our own issues onto our clients. And in our mental health system, we have, the extremely vulnerable people, and, we could do a lot of harm without being aware of what's going on deeper down for us. So,
absolutely.
I wonder if it's in the bigger body that you did, of work that you did, or
thanks. Yeah, definitely there are voices there. What I try to present here is the extensiveness of the comments, right? So those comments that were more kind of supported by many voices. There are several voices saying we need to be doing our work, but some others are completely not there. So there were 2 or 3 people max, whereas the others are like more extensive in terms of the, but I think that is absolutely essential if we are going to, how we are going to, it's not only about being regulated in your cognition or regulated in your kind of body reactions, emotions, but it's also knowing your ethical stand based on your own issues, because obviously trauma is not something that happens to them. Trauma is inherent to human nature, right? Psychoanalysis talks about the constitutive traumas, which is death, sexuality, and otherness, meaning we always have to deal with others, and we are not the only one. Sorry for our narcissism. And there are contingent traumas that are precisely those horrible things that happen in life, right? But yeah, thank you. Yes.
First, I'd like to thank you for an excellent presentation. One of the issues you brought up is something that I think is fairly important, which is the importance, like the capitalist model, kind of obliging that one maintains the optics of providing service and somehow promoting that these services are effective whether they meet the needs of the clients or not. And I'm just wondering how, like, given that funding inevitably comes from, say, capitalist-based enterprise, how do we, like, where is funding for service delivery going to come from, and how will it be made enough of a priority to receive the funding that it merits? Absolutely, yeah. Some of the normalization that I found in kind of in these interviews is precisely the scarcity of resources, right? Yeah, there's a scarcity of resources, there's a kind of amount of caseload, and that's kind of a larger scale of, yeah, the global, right? Like the neoliberalization, how, for example, there are very interesting studies that I came across with regards, for example, financialization of drugs, and how that it's kind of trying to use our taxes to pay for the gain of drug kind of companies, particularly about, for example, Pfizer, which does Prozac and Zoloft, and Yale. So then also like passing the high risk research to Yale University, and then the others gathering mainly the good money for their pockets. So yeah, I think that for us to be able to gain some assertiveness in terms of the budget, we need to, it's not that it's going to come up, down, it needs to come down, up, in terms of reorganizing, opening kind of our critical minds and our discussions from the kind of grassroots, and saying, I really think that we should have a group of so and so. I really think that we should fund the drinkers lounge in the downtown east side, right? So things that are kind of put aside, we need to fight for that within the institution at the level of our work, right? Because yeah, it's not going to come up down, I think. So kind of advocating for our patients, organizing. No, for example, I don't think that my research is going to have any changing of the system. I'm not that delusional. I have my delusions, but that's not one. But I hope that it's giving us some critical language to be able to use to counter, kind of balance a little bit the domination of certain forms of therapy within our practices. And not because it's a kind of personal thing, it's because people need more than just like a manual. People need other things. And also I think creatively, thanks, because I remember something about your question. We need to do more kind of very well established relations with community partners and agencies to be able to refer people to receive kind of other, like yoga. Which one of us wouldn't be able to live without yoga, or whatever other practice, dancing, or I don't know, other kind of therapies that we do for ourselves, but we don't think that it's going to help a client. So I don't know, massage therapy. We have a lot of massage therapy among the psychotherapists in this kind of institution. So kind of trying to bring those partnerships. I also thought about, it seems like there's a strength of policy in mental health that is moving towards self-directed
services, which is, for example, similar to what happens with people with autistic kind of disorder, spectrum disorder, or other kind of disabilities or developmental issues. They can go and decide which service they are going to receive. If they want to go to horse therapy, they can decide that. It is found that that is very empowering for people, but they're also saying, and this is one research by my co-PI, that it should be kind of reviewed that those self-directed are not too individualized in a way that kind of affects people that are more disenfranchised. So there's a lot of things that are happening in kind of in the mental health field, but we need to really start from the cell of our institution, right, of our workplace. We need to democratize. In what do I mean by democratization? I'm not talking about being the Che Guevara, but I'm talking about recuperating or recovering those things that are specific to our populations, and that respect the diversity of wealth among the people that are there to serve populations.
One last question. We'll keep it on the briefer side, if that's all right. Thank you. Just in the interest of time, we just have a couple.
Thank you. Firstly, thank you so much for trying to tackle articulating what has been so unarticulatable. This is a really complex issue, and I think you did an amazing job of starting to piece it apart. I'm really impressed. Thank you. I wanted to know, I very much agree, the part of the challenge is the optics and trying to find measurements that will be valued by funders. And like you said, checklists, et cetera, aren't what the patients need. Did anything sort of come out of your work in terms of what you think would be the outcomes that we should be looking for that would capture some of this more abstract nature of healing?
Mm-hmm. Yeah, no, it's a good question. No, I didn't go that far because it's mainly about the interpretative frame. But I think that is an opportunity for us to figure out kind of side by side what could we do to validate our quest, because yeah, it's a vicious cycle, right? It's research only validates those that are kind of randomized or whatever, checklist, manualized. The qualitative is a little bit more complicated to justify. But I think that, for example, I don't know why we don't do, I'll be totally down for organizing a multidisciplinary kind of model that is designed.
We just have a couple more minutes left.
Okay, yeah.